The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and good morning to our friends of the West Coast. I'm Marc DeCourcey, the Senior Vice President of the U.S. Chamber of Commerce Foundation, and I lead its Corporate Citizenship Center. Welcome to our Digital Empowers virtual event series around pandemics. We have a lot of great speakers today. We're so glad that you could join us. But I just wanted to start by telling you a little bit about how we got here. The U.S. Chamber of Commerce, as you may know, is the world's largest business federation, representing the interest of over 3 million businesses here and around the world. And like all chambers of commerce, the U.S. Chamber focuses on creating those conditions and environments where companies can do well, add jobs, grow economies. U.S. Chamber Foundation has a slightly different mission. Our mission is to help companies do good. And we believe there's a synergy between doing well and doing good, and one can't exist without the other. Which brings us to today. We talk about corporate social responsibility in the sense that companies have an obligation to help society. And so many companies have stepped forward in this current environment with the pandemic to help their communities that they operate in, as those who live there. So we want to get in a little bit deeper with this, but let me tell you about the event series that we've created. It's not new. It is over 2 years old, this Digital Empowers campaign. We started it with our great partners at Tata Consultancy Services, or TCS. You'll hear from them in 1 second. But we thought that technology can solve many of these challenges that we see across the world. And now, more than ever, as we're homebound, as we are working as hard as we can to help society to defeat this disease, we thought that we should have one of these sessions, the first virtual session of our Digital Empowers campaign today with all of you. It'll be one of many that are upcoming. We'll hear about more of that from our speakers later. However, I want to introduce our great partner from Tata Consultancy Services, Balaji Ganapathy. Now, Balaji, as you may have seen in the bio, he is the Chief Corporate Responsibility Officer for Tata Consultancy Services globally. And we've teamed up with them and their great expertise to bring this session to you today. So with that, Balaji, over to you to kick us off.
Thank you, Marc, and good afternoon and good morning to everybody on the call. First of all, I want to acknowledge the tremendous efforts that are being put in by healthcare workers and people on the front line all around the world to fight this pandemic and help the rest of us look towards a better future than where we are today. As Marc said, these sort of tough times call for us to come together as the private sector, the public sector, NGOs and nonprofits, as well as influencers and experts, to look at how we can create solutions to address some of the challenges that unprecedented challenges that this crisis is presenting us with. The whole purpose of the Digital Empower series, when it was created a couple of years ago, was to explore increase the understanding about digital technologies and social issues, and learn about both in a similar context, so that we can explore a data-driven, a technology-led approach to solving some of the greatest problems that we encounter in society, and do that at a local and regional level. And also foster partnerships by exploring the art of the possible. And this series has gone far and wide, from DC to Atlanta to Chicago and Charlotte. And this pandemic really struck us at a time when everybody is trying to pivot to a online and a digital model. So I'm very happy that all of you are able to join us here today, and I look forward to a great conversation. And I want to share a few thoughts as probably thought starters to kick off this conversation. First and foremost, every organization has an obligation, every individual has an obligation and responsibility during this time. Health and safety and wellness of our own families, our own friends, our colleagues and people at work is paramount. And at TCS, that's the first thing that we did as a global organization with a footprint of 500,000 people across 50 different countries. Over the past 3 months, it has been an extremely challenging environment for us to ensure that all of our employees and their extended families, our partners, our extended ecosystem is taken care of. And I'm happy to say that we, as many organizations have done, we were able to make a pivot and enable over 90% of our workforce to work from home. The second aspect was to ensure that business critical functions, which are technology led. Today, a lot of the essential services that are happening in society, whether it is healthcare, pharmaceutical, logistics, government systems, and tools, for all of them to run, technology services are important, and we are providing that around the world as an essential service. But in particular, couple of points I want to mention is that local solutions are really important to the kind of problems that we are facing. And in the scope of technology and its role to solve some of the problems that we are facing, we have to look at it from a health and safety perspective. We have to look at it from a food security perspective. We have to look at it from ability to do predictive modeling and predictive analytics in terms of where the pandemic is, where it is potential is to spread, how can we contain it, how can we prevent it even before containing it, and if not, how we can ensure that those who are not affected are safe within their own boundaries. At TCS, our research and innovation team has put a lot of thought into these areas, and what I can only describe as a remarkable altruistic effort, all of our innovation labs have opened up their solutions and offered it to the local communities around the world, including things like contact tracing, self-assessment, looking at patient tracking, all the way to drug molecule discovery, and creating or converting designs of current manufacturing setups to create masks and ventilators. Our teams are working around the clock to address this pandemic, and I'm sure you will hear from others in the call who will share similar thoughts from what they are experiencing and doing. It is also important to look at applying these at a local level. And I just wanted to share an example that in the last few weeks, in talking to several governors and local state leaders across the US, the kind of needs are very, imminent. But technology and systems that are in place, especially with benefit systems, health systems, data talking to each other, ability to look at large unstructured data and make analysis around it. These are all problems that people who are decision makers are facing, whether they are leaders of a state or a township, whether they are leaders of healthcare institutions and systems, and of national organizations that are trying to address this. So this is an opportune time to understand the role of data and predictive analytics and listen to our colleagues on the call and learn from them. Last thoughts I want to share with you, if we can advance to the next slide, is that typically how this campaign and these forums are run is to have experts engage in conversations, have great thoughts being shared, but also valuable conversations and discussions. So we look forward to hearing your questions and having a good conversation as well. And then insights from the topic that we cover are presented in this platform, which is us.digitalempowers.org. And finally, one thing I want to also mention, if you go to the last slide, is that prior to the pandemic striking us, through this partnership, we had launched an awards called Digital Empowers Awards. This is basically to recognize the role of technology in solving problems in society, looking at the future of work, crossing boundaries of sectors, and looking at the impact on a social, gender, cultural sense, And those awards are in progress. We have received a lot of positive feedback as well as entries from around the country. And I want to mention that this is something that we'll continue to promote as a way to shine the light on good things that are happening, being done by organizations and individuals to support. There is a pitch competition as part of this, which especially enables small and medium startups, social organizations who are at the cutting edge because they are so hyper local and focused on solving the most pressing problems. I thank you all for joining us and look forward to a healthy debate and learning a lot and partnering together as next steps. Thank you.
Balaji, thank you for your leadership and vision during this unprecedented time. Now I would like to turn it over to my colleague, Alexa Miller. Alexa, you can see on the screen, she is the National Director of our Digital Empowers campaign. She has some introductions to make, some housekeeping items to share, and then we can get going and hear from our three amazing speakers who they've really been instrumental in bringing the right interventions, both here in the US, but also globally, to the forefront. So Alexa, over to you.
Great, thanks. Hi all, Alexa Miller here. Echoing Marc and Balaji's sentiments, we've got a great program in store and we really want to honor all of the work that you guys are doing. So today, you're going to be hearing from three rock stars really at the helm of this effort. First up, we have Amanda Makulec, Senior Data Visualization Lead at Excella. She thrives at the intersection of data, design, communication, and global public health, and has emerged as a true thought leader amidst the COVID-19 pandemic. From there, you'll hear from Bill Heisel. He is the Director of Global Services at the Institute for Health Metrics and Evaluation. IHME is a data crunching powerhouse whose empirical model was among the first to break through the noise with global leaders, especially in regards to those social distancing policies. And then finally, we'll hear from Kuldeep Singh Rajput, who is the CEO and founder of Bioformis, a Boston-based digital therapeutics startup lauded for its remote monitoring and predictive analytics platform that's been championed by health systems, governments, and pharma companies worldwide for its early intervention capabilities. So this webinar is really going to be broken down into three components. First, beginning with the individual speaker presentations, group discussion, and then finally audience Q&A. So regardless, all participants will be muted for that Q&A portion, but we do encourage you guys to all submit questions, and you can do so through the GoToWebinar chat function. And just pop those through as soon as those come to mind. And I promise I will get to as many as we can before wrapping up at 3. With that, I think we're ready to get started. Please join me in welcoming Amanda Makulec.
Hi, Alexa. Thank you so much for having me today. As we go ahead and look to our topic that we're starting with today, I'm going to actually launch us off thinking less about the details of the models and more about the broad conversation on visualizing and making sense of COVID-19 data responsibly. I am the Senior Data Visualization Lead at Excella. I also moonlight as the Operations Director for the Data Visualization Society. And we've published a number of articles talking about this idea of responsible visualization and how can we do that when there's so much uncertainty in the data. And there's no doubt that there is a ton of data in the world around us today. Every day we're inundated with new charts and graphs, whether they're updates to ones that have become familiar, like the Financial Times tracker, or new versions of different charts that help us try to make sense of this uncertain information. We also saw the emergence of this flatten the curve infographic that helped us try to make sense of what we could do as individuals in terms of slowing the spread and helping to flatten the curve of COVID-19, really trying to keep that curve below the healthcare system capacity line. And that flatten the curve graphic is really interesting, not just for the way it kind of simplified and shared a key and critical message at a key time around social distancing, but it also can help be a tool for us as we go ahead and try to make sense of some of the more complex models coming out around what will or could happen with COVID-19. So as we look at different models, we see a lot of different ways that charts and graphs are being plotted with different parameters and inputs and outputs, telling us what could happen with COVID-19. All of these models use different methodologies and are based on different underlying data sets. Some have shared data sets, but many bring in different factors and ideas. And as we try to look at these models and the outputs and the visualizations and make sense of them, we can see that the flatten the curve graphic is something that can help us all actually use this mental model we now have and make sense of the charts that we see. But that may also create some surprise for us as we start looking at these charts and graphs, like this example from the Imperial College study that goes ahead and shows us that the actual curve or the wave that happens with the COVID-19 cases is actually likely to be a little bit wobblier than what we see in these simple infographics. So while these mental models are valuable, now we're challenged to find ways to wrap our heads around the different ways that our charts and graphs can help us communicate about what might happen and to think about the uncertainty in those visualizations. We've even seen different hubs try to bring together the different models in one place. This example from the Reich Lab and this visualization that they've created plots different models and what their projections are for different national level forecasts as well as state level ones, and tries to help us make sense of the variance that we see across different models, which if that doesn't speak to the uncertainty we have around what the shape of this curve will look like, I'm not quite sure what does. But they do a great job of actually pulling together these different data points all in one place so we can see that variance. And we can look at the various confidence intervals that help us try to understand the uncertainty in the underlying data. As we try to make sense of these models, there's two kind of key questions we can start with before we even see visualizations being plotted. One is this question around what method is being used in the modeling approach. And the second is what data is that model based on? And making the assumption that everyone on the call are not epidemiologists and very highly skilled at building these complex models. One area that we all can become more versed in is the kind of data that is feeding these models, especially the COVID-19 case data, the deaths data, and the uncertainty wrapped around it. So as we think about why we see so many models and visualizations popping up, I want to point to the fact that this is a unique pandemic in the level of accessibility of data and information. The Johns Hopkins University dashboard, which I've heard rumored is getting more than 1 billion hits a day at this point, provided all of their underlying data to the public-facing community for use by other educational groups so that they could go ahead and experiment with it and build their own models and make their own sense of it. That's wonderful in terms of data sharing in the public domain. It also creates challenges, though, because we need to be more critical consumers of what we see shared and posted on social media as we're making sense of which of these models and charts and graphs are worth our trust. So as we think about a couple questions about the underlying data, one simple question is, what is the definition of a case or a confirmed case of COVID-19? As you can see in this example from the Ohio Department of Public Health, they're actually reporting cases with two different breakouts, both their initial confirmed case count and then also this expanded case definition of probable cases. As we try to go ahead and make comparisons between states and countries, we need to make sure that the way we're defining a case is the same or comparable across those different states or countries. We even saw this early on when we were looking at the charts and graphs of the data out of China. And if you look here at this reference line on this chart from Data Wrapper, you can see this little blip that happened, which looked a lot more startling when we were back in February, around the point at which China changed the way it collected its data. And it's important that we have various markers and ways on our visualizations to communicate this kind of information so that I, as a reader, don't have to ask what happened, and instead get some clear information about how the data collection process or the definition changed. We can also think about the ways in which different shares of cases are being detected. I think it's been well reported that the number of confirmed cases we have are really right now a function of the number of tests we're doing in a lot of ways. And this model and this approach, which didn't look at modeling the projections of cases, but instead trying to make sense of what share of cases are we actually recording, this out of the London School of Hygiene and Tropical Medicine, tried to plot and estimate what share of cases we actually are reporting in our reported cases. So as you look down this chart, you can see that the farther left the bar is, the smaller the share of cases being reported. And if the bar is wider, we have more uncertainty around that estimate. So if we look at the US, there is an estimate ranging from 11 to 26% of cases, with a center around 12%. And what that tells me isn't necessarily the precise point at which that I'm going to then calculate the number of cases in the US, but rather just the level of uncertainty in our data. There's also an important piece of understanding data and being a good consumer of data and thinking about how the case data is reported. This is a snapshot of the reporting form used by the CDC to transmit case data about each COVID-19 case. And as you can see, it asks a number of different questions about things like symptoms and about demographics about the patient. But this takes time to fill out. So we've seen stories about how we see these little blips sometimes on Sundays when we see the curve appearing to flatten. And that in some cases, that may just be that there are fewer reports being submitted because of the fact that these cases are being logged based on the date they were confirmed, not the date the swabs were taken. There's also just some odd nuances we're finding in how study data, trying to dig in and understand the nuances and disaggregations of COVID-19 is being collected. Here in this example, in some communications about a paper, it was surfaced that one of the reasons that there seemed to be a smaller proportion of smokers in the COVID-19 case data in this case is because they couldn't answer the question of, do you smoke, because of their older age and serious illness. That's not a reason to conclude that someone isn't a smoker. It just adds more unknowns in our underlying data set. If we look to those unknowns, we also see those unknowns not just in small nuances around things like smoking and behavioral interventions, but also in some of the data we see reported in the broader news media. So if we go back to some of these sources, like the Morbidity and Mortality Weekly Report from the CDC, they put out estimates back at the end of March around the prevalence of selected underlying health conditions among patients with coronavirus disease 2019, or COVID-19. And as we look at that, NPR did a great write-up talking about this and other nuances in who was being most impacted. And they went ahead and made a comparison with some clear statements about the various sample sizes of these different groups. And we can make a comparison looking at pre-existing conditions against the other conditions that are out there. But what really drew my attention in was that these are preliminary statistics from 6,637 cases. And when we dig into that, the question I start to ask then is, at the end of March, didn't we have a lot more cases than that in the US? And if we go back to the actual source data, we can see a table that shows us just how many records had unknown data or information. And again, speaking to the fact that we have a lot of gaps and unknowns in our information. There are unknown unknowns, these gaps where we just don't have data or information. And then there are things that we don't know yet because of how new this pandemic is. So as we think about how these various mathematical models and other ways of trying to make sense of a complicated situation translate into these simple user-facing visualizations, whether it's on a map or a chart or graph, we have to think about the ways that there are certain things and certain nuances that can be lost as we translate that information into those simple visualizations, which are excellent for communicating information, but also can overstate the certainty of what we're seeing here. As we look at these charts and graphs, we should look for explainer information, data and little data points in text that help us actually make sense of what we're reading and we're seeing. And I appreciate some of the great visualization folks and modelers who have added a lot of explanatory information to help us make sense of what we're looking at. And so I would close with, as we move into talking about some of these models, have some empathy for the people trying to model this disease right now. They're doing us a great public service by trying to find ways to make sense of what could happen related to COVID-19 cases. But it's really complicated to do that with an emerging disease and in a pandemic. You have to understand nuances about the susceptible population, the infection rate, the fatality rate, all things that we're making our best guesses at now. So I would close with the words that I think have been passed around a lot lately, which is that all models are wrong and some are useful. And so as we go ahead and look at all the models that are out there and try to make sense of them, let's think about in the visualizations, what's represented, what's not, where is there uncertainty, and try to figure out what our kind of best takeaways are that can inform our own individual decisions about how we continue to live our lives in this kind of strange new world. So with that, I'm going to go ahead and wrap up and hand it over to Bill Heisel, who's going to speak to us about the IHME model.
Great. Well, thanks, Amanda, and thanks everybody for joining. Really appreciate everybody taking time out of the day to talk about modeling. I would have not, a year ago this time, I don't think I ever would have been on a webinar with almost 300 people who are interested in talking about disease modeling. So it's exciting. We've been doing it here at IHME since 2007. And so I think one of the things to think about, kind of to set it up, kind of teeing off what Amanda said, is there are a lot of people who are super interested in data right now and super interested in modeling who weren't doing this for very long. And so something to think about is when you're looking at the data and you're getting the information, not all organizations are equal in terms of their experience and sophistication and what they're bringing to the table. So it's important to also kind of understand where's this coming from? What's the kind of foundation under it? And the way I like to think about the models is Amanda's right, that some models are useful and all models in some way will be wrong. And any model, in being transparent, should be providing uncertainty around it. And at IHME, I'm showing this a screenshot here of a tagline that I actually helped devise when I first started at IHME back in 2007. And what we said back then was that IHME was about accelerating global health progress through sound measurement and accountable science. So how are we accelerating progress? What was our thinking? So back then we were mostly modeling the past, and actually we can continue to model the past. We're taking in all the data from around the world and we're trying to create a consistent, coherent time trend and make comparable estimates between different health conditions. And we were doing that not just to let people know what happened in the past, but so that they could change the future. And so NPR really said it nicely recently when talking about these different models and the way that Amanda had summed it up, in saying that these forecasts are not our fate. What we are trying to provide here, and I think what we and others are trying to provide, is a view into the future and a scenario that you can actually actively change. And what we have always known would happen, and what indeed has happened, is that people would take steps to change those forecasts, to change what we were seeing in the future. So they would do things like the simplest thing that we all might remember in the early days of this pandemic were wash your hands, don't cough into your hands, pay attention to how you're coming into contact with other people, avoiding people who appear to have signs and symptoms, all those basic things before the more strict social distancing measures came into place. So people even early on in the pandemic were starting to change their behavior, and we knew that would alter the forecast. And that was actually the main reason we got involved in modeling out and forecasting the projection of the disease. So accelerating global health progress through sound measurement and accountable science. So one of our main funders, the Gates Foundation, uses the same term in the way they talk about the goalkeepers' work they do. They talk about accelerating progress because they don't want to assume that, as used to be the case, that more than 12 million children would die every year before their 5th birthday. They didn't think that was acceptable. And so they've worked hard, and others in global health worked hard to change that trend. And so indeed, we've seen year after year those trends come down. And so now, it's around 5 million children a year die before their 5th birthday. Still an unacceptable number, but far lower than what we saw when we first all collectively started working as a society to drive that number down. And that's the type of thing that we want to see happen. You can project forward how many children are going to die from childhood diseases. You can project forward how many hospital beds are going to be needed for COVID-19, and then you can say, what can we do to change that projection? So one of the reasons we got involved in modeling the disease and the pandemic was you were seeing a lot of headlines early on. It's hard, when we say early in the pandemic, I mean, now we're just talking about weeks and months, but you were seeing that things like it infecting 81% of the US population and causing 2.2 million deaths in the US. So there was a lot of fear out there, and as Amanda said, there's a lot of uncertainty out there. And so we thought, what can we do to maybe bring a little bit more certainty to what could happen in the future and start to give people some guidance on what they can do to change that course? Again, that forecasts are not our fate, that we can actually do something about it. When you think that 81% of the population is going to become infected with the disease, it can seem overwhelming, and you can almost feel like there's inevitability to it and there's nothing we can do. What we found is that part of what was going on with a lot of the modeling of just the pure case counts was that case ascertainment is so difficult. Amanda showed that on a chart earlier too. It is so difficult to know how many people are really getting infected with the disease, especially in a country like the US, where testing to date has been so sparse. So in certain countries, they've done an excellent job of testing wide groups in the population and coming up with pretty solid case counts. But even in the best cases, the case ascertainment is nowhere near as well done as you can find with deaths. So with deaths, you still are going to have people who are missed. You're still going to have undercounting. You're still going to have miscounting. But the error rate is a lot lower. And we found that anchoring our model to deaths provided for a much more solid projection into the future on what we would see in terms of resource use. So our initial focus was, let's help hospital systems prepare for what's going to be coming. Let's help them see what the worst case scenario might be. And so we would repeatedly find ourselves saying in these conversations with health systems, prepare for the worst, and then hopefully we can change the trend and instead see the best. And that's indeed what's happened in a place like Washington State. For those of you who haven't seen it, I'll just pull it up on the screen. The basic model that we use and the way that we present it, in, I would say a fairly simplified form, is an example here is for the state of California. So going back in time, we had no deaths. So we were showing that there was just a flat trend in the number of deaths per day. And then as we started to pick up death counts from the reported death counts through either California itself or through other public reporting systems, we would then add that into the model and start to project forward. So you see these death counts were going at like 1 today, then getting 5 per day, 15 per day, 14 per day, 22, 26 as you go. And some of that lumpiness that you're seeing is exactly as was discussed. There's some problems with the reporting. There's lags in reporting. We're not correcting for those lags currently. We're just allowing it to help inform the trend. But we are saying, what do we think the overall trend is? We didn't really think here on April 9th that there was a true peak and that it was actually plummeting. We thought the trend was still going upward, and so we continue to project the trend upward until April 15th. Then we are predicting now kind of a downward trend through May. This big shaded area that you're seeing around there is the uncertainty, and we feel that all of these models out there that are projecting cases or deaths or resource use, the best thing to provide to the public is that uncertainty bound around it. Again, if you think about the worst case scenario being there at the top, being 249 deaths per day at the top of the shaded area, and the best case scenario being 8 per day. So you could plan for the worst, which would be a very high number of deaths, and you could hope for the best, and that would be a low number of deaths. And now we're starting to see California, like most of the West Coast, took very strict measures to contain people and to put social distancing in place. And so we have seen that curve follow more of the best case scenario, whether it's California or Washington or some of these other places. That's what we're starting to see play out. We also think it's really important, no matter what the organization is, whether you're like IHME and you've been in the business for more than a decade and have made modeling this type of trend line your core business for now 500 people at IHME, or whether you are new to it and want to kind of try out a model that you found or want to come up with some software solution, that it's important to really try to explain what you're doing as you're doing it. So we are updating the model on a regular basis, and we are putting out these updates about what we are doing to the model as we are changing it. So we're now predicting when the current epidemic phase will end, and then we are talking about when we can start to see a shift to the containment strategies in the US. So I'll go back to the tool and show you what that looks like. So here in California, we're saying once we get down to this death count of 0 per day around May 17th, we're saying May 19th, we'll be in this containment phase. And then what will that look like? The next phase of the model that you'll start to see coming out from IHME will be how are we predicting and trying to handle potential resurgences, and how will we show that into the future. But for now, we're saying we have this phase, we think in June, July, up until August, where we see there could be a containment of the pandemic as long as strong containment strategies are put in place. And we talk about it right here at the top of the screen: testing, contact tracing, isolation, limiting gathering size. Also important, I think, for people who are out there making use of all these modeling trends, to be able to put it in the context for people so that they can understand the numbers. So we don't get back to a situation like I described earlier, where we were saying 2.2 million people are going to die in the US. Many people in the audience know this, but about 2.8 million people die in the US every year, 2.8 to 2.9. So 2.2 would be obviously a very sizable proportion of those deaths that happen anyway. And so you're talking about massive increase in deaths, and even if there's some replacement for some deaths that don't occur, a very, very substantial increase. But to put it in the context to say, and as this great piece in the Washington Post did during the epidemic around the 16th of April, said that, you know, here's where this ranks currently in terms of a given week, a typical week. COVID-19 at this point was ranked number 2 in terms of the amount of deaths it was causing, so second only to heart disease. So even though we're seeing a spike and we're expecting it to go down, they're saying this is a serious threat to human health, and we should be as focused on as we are now and do whatever we can to mitigate it. So it's a nice way to put it into context and to show, okay, well, here's cancer, and here's chronic low respiratory disease, and here's what accidents cause. In terms of the what if, that is, and the what now, people often ask when they see modeling. We were asked by the governor of the state of Washington to help kind of provide some sense of when the economy could start to reopen. He actually posted this on his Facebook page shortly after we had shared some models with him. And I think it was useful for the public to see, even though this is the kind of thing that is happening very much in real time at IHME as we're providing this guidance. And it isn't in the typical way of doing things that we've done in the past, where we're putting it out in a peer-reviewed paper or we're having a big symposium or something. It's coming out in a very rapid fashion. And in this case, this piece came out that he put on his Facebook page to show this upward trend that you were seeing there for California, but in this case, it's showing Washington in the deaths, and then it coming down, and it should be coming down this nice smooth dotted line if we continue social distancing. And the governor was saying through our guidance that if we reopened the economy, you would have this extra number of deaths in here. If you reopened it around May 1st, and if you reopened it around June 1st, you have these deaths here, the preventable deaths. Social distancing starting on April 10th versus April 22nd. What that would mean in the number of deaths that might occur because of an uptick. And so that's very useful guidance to be able to bring out and be able to tell the public kind of what the latest thinking is and where he was going with that. Another thing I would say in terms of being able to explain to people a little bit more about what goes into the modeling effort and why and how you can kind of visualize these different models and interpret them. People have taken our numbers, like Mike Freeman from the University of Washington used to work at IHME and now teaches data visualizations, and he took our numbers and he took the New York Times way of showing the country in these nice little squares for each state to be able to see quickly in a snapshot, where were things really going up dramatically. And you can see this very dramatic spike in deaths here in New York that is, even though this now is several weeks old, this is what we have seen come to pass. We've seen a similar spike here in Michigan, and you can see that it all in one nice spot, kind of where things are going to be higher and lower. And similarly, you did a comparison of what happens when we change models, every few days, as we're changing the models and therefore changing the trend and doing exactly what I said at the beginning, that we're not assuming that the forecasts are fate, we're assuming that you can change the trend. And so what happens when we change the model? So he shows kind of whether the estimates went up or went down. And so in a place like Connecticut, you see this significant dip from one model to another model. We went down by 67,000 in terms of the predicted outcome for hospital beds. In New York, we actually went up, and in New Jersey, we went up. Massachusetts went down, Rhode Island went down. Most of the country at the time, at least when he did this snapshot, it wasn't a dramatic change, even enough to show in a chart. But I thought that was a really great and useful way for people to make use of some of these numbers in their own work. Esri has taken the numbers and they put them on a map, again, to be able to helpfully show people, when is the peak coming or is it already passed? So in the case of the numbers that we've put out most recently, they pulled them in and showed Sweden is still 8 days before they're about to reach the peak of resource use, assuming social distancing stays in place. But right next to it here, you can see that Norway is now a few days past the peak. So we're saying 14 days ago, they've passed the peak. And the last thing I want to leave the group with before going is just kind of come back to what the NPR report recently said in talking about the modeling efforts. And I think this is a really great point for people to think about when they're using models, where they're developing their own models, is that models are forecasts and they're not our fate, and our behavior can change the forecast in a big way. And that's exactly what we've seen play out in this pandemic. We feel quite grateful to be able to have jumped in the way we have and been able to contribute. And we're also quite grateful to all the people who have made the data open out there that we've been able to access and pull into the models. And we're very grateful to all the people around the country and around the world who have put social distancing at the top of mind and been able to take in some cases for them, it must have felt like a radical step to stay home, to not go to work, to have their kids at home with them, to not go to the grocery store, to go to the bar, go to the restaurant the way they used to, and to be able to really limit the impact of the pandemic. So thanks, everybody, and I will turn over to another presenter. Okay, Kuldeep, do you have it now?
Not yet.
Okay.
Perfect. Hi, everyone. I'm Kuldeep, founder CEO of Bioformis. Pleasure to be here. So what I'm going to talk about, of course, is slightly different from data and modeling, but how we have been really able to leverage technology and the platform we have built previously for other disease areas for COVID and customize it for COVID and manage patients with COVID. Very briefly, Bioformis is a digital therapeutics company based out of Boston. And our primary focus really is to build software-based therapeutics and remote monitoring technologies to be able to monitor patients with complex chronic conditions, and primarily as a company have been focused really on cardiometabolic, respiratory, and oncology. And we have built a single universal platform which has all the key components to be able to put a monitoring platform or a digital therapy together. So, one of the things during COVID, and these are some old stats, but over 2 million people affected with COVID and rapidly increasing. And one of the things when a pandemic like COVID breaks, so much is unknown, and every second counts. And one of the key things what we have learned so far, if you look at this publication from Lancet, which showed that once the patient gets infection, there's this incubation period of 5 to 6 days, after which the patient actually starts showing up symptoms. And that's the duration when patients or people are in fact transmitting the disease, and really being able to take social distancing seriously, and even be able to detect these changes well enough physiologically, so that these patients could be isolated. So what we essentially put together is a platform in a matter of a couple of weeks. We customized a platform called as BioVital Sentinel, which has 3 main key components to it. The first one is it has a sensor along with a mobile app for active and passive data capture. We capture multiple physiological signals using sensors and variety of data, including cough, symptoms monitoring, communication between caregiver-patient using the smartphone app. All that data goes to our second component, which is our analytics platform, which has the ability to detect these subtle physiology changes, which we know are precursor to symptoms or even patient getting serious or adverse event, and finally relay that on a clinical dashboard for nurses and caregivers to intervene. Of course, it starts with the sensor, and if you can see, it's just a wearable armband. It's a clinical grade sensor you wear on your arm and strap it on, weighs less than 10 grams. The device has ability to capture or 15 plus physiological biomarkers, and primarily things related to COVID, including heart rate, continuous respiration rate, pulse oximetry, temperature, blood pulse wave, activity data continuously, and then relay that via a patient-facing app, which also has other aspects, including symptoms monitoring, continuous physiology monitoring, as well as audio samples of different types of cough to detect progression in disease. And relay all that information after processing to a clinical care dashboard for clinicians to manage and intervene. So one of the key aspects what we have seen essentially is we have, of course, deployed it globally now in 4 different countries, and primarily the applications are different depending on the need. Starting with, first of all, in the US, if you look at ED and hospital crowding in some of the states, how do you really bring that hospital level care back into patients' home and send low medium risk patients into home and provide the same level of monitoring and care? And in fact, the time was, it was very timely. This year, earlier in Jan, we published data which essentially showed the same concept of home hospital program for patients with respiratory illnesses, infection, and heart failure, where we proved early detection and continuous monitoring reduces hospitalization by over 70%, and of course, the overall cost of care by 38%. Apart from that, the second use case, what we have been focusing on is people who are quarantined, and how do you monitor patients who are quarantined, continuously capture data, be able to use analytics to be able to pick up those subtle physiology changes ahead of time so that those patients could be tested and in fact isolated so that immediate care is provided. And finally, as you know, healthcare staff and healthcare workers are significantly at a higher risk, and they've been working so hard. So how do you monitor these healthcare staff to be able to continuously track them and provide them early care if required, or even isolate them? So I just wanted to show a couple of examples, and we pulled this together just last night for showing. And here's the example of one of the patients in Hong Kong, where we have been monitoring people or patients in isolation wards. These are positive patients, and the entire purpose is eliminating healthcare staff to go and manually intervene or manually take measurements from these patients on an ongoing basis, and of course, saving those PPEs and being able to detect these symptoms early enough. In this case, as you can see, once the patient was onboarded, a positive patient, and we are monitoring multiple physiological signals, and all the way from day 2, day 3, he was stable, of course, progressing gradually. And on day 4, the patient significantly exacerbated heart rates, respiration rates, temperature, significant elevation, along with patients, having multiple symptoms on the day 2 and day 3. The patient was eventually transferred to the ICU and put on ventilators. So this is, of course, an example where how you can utilize healthcare resources inside the hospital properly by having proper isolation center and continuous monitoring. Other use case, what I wanted to show was specifically, this was a patient quarantined, and once the patient was quarantined, he was negative, PCR values were negative, and the patient was continuously being monitored. And during the first 2 days, as you can see, his combined BioVitals index, which is our early warning score, which combines multiple physiological data aggregated, and first 2 days perfectly fine, and on the 3rd day he starts exacerbating. His physiology signals start deviating, deviations in pulse oximetry, the gradual increase in temperature, respiration rate gradual increase, but the patient reports no symptoms because they are technically in Hong Kong asked to report their symptoms 2 times and 3 times a day, but the patient is not reporting, and in fact, when called, said that he had no symptoms. But on the 31st, he was brought in to check his PCR values, and the patient was turned positive. So, this is one simple example of being able to continuously track patients, be able to detect these subtle changes early enough, and be able to, keep these patients away and isolate these patients. Of course, we all are learning more about the disease, and we will soon be publishing data of over 200 plus patients on our learning about the disease itself and how physiology monitoring and digital technology has helped primarily clinicians in hospital as well as government agencies in monitoring and isolating these quarantine patients. So with that, I'll probably pass it over to Alexa.
All right. Thank you so much for those two great presentations, Bill and Kuldeep. I know we have a limited amount of time for questions, so I want to raise a couple that we can hopefully tackle a few of our viewer questions and some of what we'd hope to cover in our group discussion. Bill, if you want to, you could turn your video back on so we could also see you. So one of the questions that's come up is around how the models and the data gets used. So do you find your models are being leveraged by policymakers, whether it's public health sector agencies or healthcare systems, or more by the general public? And are these audiences needing or looking for different types of data or projections? Bill, do you have thoughts on that from the IHME model?
Sure. Well, in our case, it's been both. We've also had millions and millions of hits on the site. Like you mentioned, the Hopkins data, way more hits on the site than we've ever had. Just it's been we haven't crashed the site yet, but it's been quite a high number. And but the policymaker engagement has been pretty far and wide. I mean, going from, as you all know, probably from the White House engagement, where we're now regularly engaged with the task force there to help inform the modeling there, and then to different governors' offices around the country. And I would also include, especially since this is a chamber presentation, the private sector. So we've had more engagement now with, I would say, almost every sector of the economy, from industries that you would not think would necessarily have some sort of COVID need, but then you stop and think, well, yes, of course they do, because they all have hundreds and thousands of employees. And so of course they all are interested in the same thing. How do my employees go back to work? How can they do so safely? So there's a lot of questions along those lines that are coming our way.
And can I just ask a follow-up on what do you say when someone says, how do I go back to work? How do I bring people back to work?
So part of what we're doing is we're trying to give people the same kind of information that we're giving to the public, and the policymakers are trying to say, here's what went into our model. Here's what we're saying of it's going to play out over the next few months, which is now on the public tool. And then, they, like everyone else, we're trying to point them to the same kind of information that people have that is the best science available on how do you protect yourself from any sort of infectious disease, but what do we know specifically about this one? So there's a lot now out there about what people can do. And you're already seeing this play out in all kinds of companies where they're putting up shields, or that people wearing protective equipment, or whatever it is. And we're talking to an industry now about how they can have a quarantine phase, testing, quarantine, testing, for getting some people back to work in a very big sector of the economy.
Kuldeep?
Yeah, no, I think, from our perspective, we have been very focused on helping clinicians manage these patients, right? Two kinds of things. One is government agencies to really be able to put, in Hong Kong, for example, the government made it a mandate that people who are essentially quarantined, everyone would be put on continuous monitoring to be able to really track their physiology data and put protocols in place at what point in time they would get tested. And as you have seen, Hong Kong, Singapore have been fairly successful in testing rapidly, but also using technology to prevent that. I think that's point number one. The point number two is really clinicians are understanding how to better manage their patients by learning more about the disease. Right now, initially when the COVID thing started, people were just using temperature monitoring to be able to say that, if there's elevation in temperature, the patient is at a high risk. But we have seen situations where it might not just be the temperature, but it might be other physiological signals, which might be, directly correlated with COVID positive cases, and really helping clinicians understand that and helping them better manage their patients. Either it is therapeutic decision making, but also I think pharma, because pharma, of course, they are running clinical trials, and really helping them design the right digital endpoints as they validate this, their drugs rapidly. So these are like three different things how we have been involved.
So I'm curious how one of the questions we have from the audience is around this idea that we're going to see future spikes or future humps in these epidemic curves. And Bill, you shared the example of what had been shared by Governor Inslee. As we think about kind of looking forward and looking to the future, how do the larger models and data that we're seeing help to inform and make sense of that when most of the models that we see projected have this kind of flattening that happens and doesn't bump back up again? And then at a small sample size level, Kuldeep, how does the data that we collect from more of these clinical patterns help to inform what some of that looks like? Is there some value at looking at those different data points together?
Yep. Certainly. I think, certainly we are ramping up our patient numbers, but I think even when there is a flattening of this curve, there is always a risk that, patients will still get infected if the economy and the market opens up. And I think it is critical to realize that right now, hospital systems are working super hard to adopt technology to be able to manage their patients even remotely, because one of the things is, like Bill mentioned, there are patients with other complex chronic conditions like heart failure, oncology, etc., who are highly prone to COVID. And how do you keep them out of hospital, and how do you remotely monitor them is going to be critical. And first of all, learning more about exact signs and symptoms will really guide people, of course, to continuously monitor them and take care and take precautions so that they get tested at the right time, but also help health systems and patients, as well as government agencies, to put processes in place on how do you continuously manage these patients, because we have been in discussions with multiple governments right now, including Singapore, Hong Kong, NHS in the UK, where they aim at providing everyone who enters the country for the next couple of years to continuously be on monitoring, to continuously track them, provide the critical care need whenever required, and provide attention early enough and get them tested.
Yeah, and I'm mindful that we're just coming up against time, so I might have to go ahead and hand it over there to Alexa. But it's been great talking to both of you today, talking a lot about the uncertainty underlying these different models and the challenges that we face in kind of making sense of an uncertain world. So thank you both for all of your work that you're doing respectively to try to make sense of all of that data and information. Alexa?
Thank you, Bill, Amanda, Kuldeep. This was awesome. We had a ton of great questions coming through, so I'm going to do the best that I can to take those offline. We also had a number of people ask if this recording would be available. We will send you this link as a part of the follow-up, and this footage will be archived on the Digital Empowers as well as the U.S. Chamber Foundation event site. So this presentation here today was the first of our three-part series. Tomorrow, we will be live on Twitter covering all topics related to tech for good in the COVID-19 era. I'll be joined with tech experts from TCS and from the Information Technology and Innovation Foundation here in DC. And then Thursday's presentation is really going to be a group discussion around digital mental health and virtual community building. I mean, how we take care of ourselves and others right now matters so much. So please join in this conversation. Tune in to that discussion. We'll have the co-founders of Talkspace and Ginger and a few other startups on the line to share their perspective.
Great.
Okay. Thank you so much for your time, Alexa, and for having us today. This was fantastic.
Thank you all.
Thanks, everyone. Really appreciate it.
Thanks, everybody.
Bye now. Stay safe, stay well.
Bye.
Thank you. Bye.